Hey guys, it's Monica. Look at my new setup. I have a little plant here that's definitely real, so hopefully I can spruce this up a bit in future videos. So today we're going to be talking about discharge destinations. So this is a topic that I really wish I understood before I even got to residency, because when you're on wards, you're going to hear terms like SNF, ALF, ARU, LTAC, and you're going to be like, what the heck do those terms even mean? Well, these are all discharge destinations, meaning where a patient can go after they're discharged from the hospital. And as a provider, it's actually up to you to decide which place is the most appropriate. So in this video, we're going to first go over the options for discharge destinations, and then we're going to do a quick overview of the factors that you need to consider to decide what place is the most appropriate for your patient once they leave the hospital. So here are the options for your discharge destinations, and we're going to go through each of them and talk about what they actually mean. So the first destination, of course, is going to be home. Anyone can go home. Even if you recommend that a patient goes to a facility for a little while before they transition home, the patient can decide, of course, if they want to go home. Now, if you are going to be sending a patient home, you want to set them up for success, and that is where home health comes in. So the patients most appropriate for home with home health are those who have skilled needs, like they have nursing needs or physical therapy needs, for example, but they're too weak to really get out of the house much. So home health agencies send these people out to the home and provide the patients with these services at home. So by people, I mean physical therapists, occupational therapists, speech therapists, and nurses, etc. So these people will come by and do a quick initial visit and see how many times a week they need to come to provide these services to the patient. And the number of times a week the service is going to be provided is going to depend on the patient's needs. It can vary from just once a week to several times a week. So one example of a patient who's definitely going to need home health is one that is well enough to go home, but they have a skilled need like IV antibiotics. So they're definitely going to need skilled nursing to come to their house and teach them how to administer their IV antibiotics. So let's move on to the types of facilities a patient can go to. So there are two types of care that a facility can provide. Medical care, so nursing needs, MD visits, and rehab, so physical therapy, occupational therapy, and speech therapy. So now let's start with an acute rehab. So the goal at an acute rehab is to return a patient to their pre-admission functional status. So again, the main goal is rehab. Now the key thing here is that a patient needs to be able to tolerate at least 3 hours a day of physical therapy or 15 hours a week. Now that's a lot of rehab. So you have to consider whether or not a patient has the energy level or the mobility to even do that amount of physical therapy, and the patient has to have the potential for measurable improvement in their functional status if they were to engage in that amount of physical therapy. Patients with skilled nursing needs like IV antibiotics or wound care can still go to ARUs because there are MDs on site and nurses. If there are medical issues that arise during their stay in the ARU, so simple things like cellulitis or UTI, there is an MD that can address those issues without having to send the patient back to the hospital. So let's move on to a skilled nursing facility, or SNF for short. So skilled nursing facilities, or SNF for short, are like a step down from the hospital. So patients have a lot of needs, skilled needs like IV antibiotics, wound care, lines, tubes, drains, etc., but they don't need as frequent medical attention or nursing attention as they did in an acute care hospital. So SNFs will have smaller nursing ratios, meaning each nurse takes care of a higher number of patients, and they'll have an MD.
Wow, not an attractive place to pause, but I had to correct myself after filming. So patients who were just transferred to a SNF from an acute care hospital will be seen by an MD within 72 hours of arrival. But after that, the MD can decide how often a patient needs to be seen. The minimum is once every 30 days. But an MD is always on call so that if a patient gets sick, there's a physician to reach out to.
So rehab is also included in the services at a SNF, but it depends on how much rehab a patient needs. If a patient doesn't need as much physical therapy, then they won't be in a subacute rehab bed. They'll just be seen by physical therapists maybe 3 times a week. Now again, the way they figure out whether or not a patient's appropriate for more therapy is based on how much the patient can handle and how much potential the patient has to make measurable improvements. So in summary, a SNF would be appropriate for a patient who has a lot of skilled nursing needs And they could still use some level of MD or nursing monitoring, but just not as much as they would in an acute care hospital. But they need more rehab and more nursing attention than a home health agency would be able to provide. So the last facility I'll mention is an LTAC, long-term acute care. You can think of an LTAC as continuation of intensive medical care, but over a longer term. So patients are sick enough to require complex medical care, but they're stably sick. So not much changes from day to day, but they are expected to recover. It's just going to take weeks to months. Now, what do I mean by complex medical care? So these are patients who would be in the ICU if they were in the hospital. So a primary example is ventilator support. So LTACs can take patients who require a ventilator for more than 6 hours a day. Other examples include patients who have complex burn or wound care needs and those with severe brain injuries. So patients at an LTAC receive around-the-clock intensive care. So an MD sees them every day just like they would in the hospital. So again, the only difference between an LTAC and an acute care hospital is that these patients are more stable in the sense that not much is improving from day to day, but they are expected to eventually recover just on the order of weeks to months. So a classic example of a patient who might go to an LTAC is a patient who is dependent on a ventilator, but it is expected that they'll eventually be able to be weaned off, but it'll just take a really long time. So instead of them occupying a bed in an acute care hospital for weeks on end, they can be moved to an LTAC. Now at this point, you probably have a decent idea of what to consider when you're deciding where a patient should go, but let's put it together in an organized way. So there are 4 major aspects that you need to consider. One is skilled nursing needs. So skilled nursing needs include all the things here. So that's lines, tubes, drains, wound care, IV medications like antibiotics or fluids, nutrition, so TPN or tube feeds, or even medication reconciliation. Now, if you're taking care of a patient, I would hope that you would know whether or not your patient has these needs. The second category to consider is rehab needs. So sometimes it's hard for us to figure out how functional a patient is. So sometimes we ask for help from our physical therapists and occupational therapists in the hospital to tell us what they think the patient's rehab needs are. By the way, the difference between a physical therapist and an occupational therapist is that a physical therapist works on a patient's mobility, whereas an occupational therapist helps the patient with their activities of daily living. So that's why it's really important to get a sense of not only the patient's mobility, but their functional status. And then there's also speech therapy. So speech therapy also includes swallow therapy. So if you have a patient who is very weak now, doesn't have a strong swallow and is at high aspiration risk, but they could improve with some rehab, they might be appropriate for speech and swallow therapy. The third category is respiratory needs. So is the patient on a ventilator? Are they requiring around-the-clock nebulizers? Do they have a lot of secretions and they need frequent suctioning? So these are the types of patients that might qualify for going to an LTAC. And then finally, the fourth thing to consider is how much support the patient has at home. So there are sometimes patients who might be able to do well at home, but only if they have a lot of supervision from a family member or friend or a caregiver. But there are patients who are debilitated who live alone and don't have any support system. So these are patients who might still be able to go to a facility so that they can recover that last bit before they go home, and then they have to be independent again. All right guys, that's it for the video. Thanks so much for watching. Please like and subscribe for more videos on how to succeed in medical school and residency. And please feel free to also follow me on Instagram. Bye guys.